Hello, hello, hello. Good evening, everyone. It's been a long time for me. I haven't been on live. I haven't been actually on social media in about a week. I went through a really busy phase at work last week, and my week was incredibly stressful. So, hey, Courtney. So, I didn't get a chance to log on and do any teaching. So, I want to apologize for that because I'm really trying to be consistent with the information I'm putting out. I get a lot of good feedback from people that are actually kind of looking and waiting for the information and things that I have to talk about. Well, this is a topic that's been on my mind since last Wednesday that I wanted to talk about. Just very simple. Nothing that really goes into deep detail. What I want to do is just touch the surface and kind of explain stuff at a very basic level so you could kind of understand what's going on. Good evening. When you see things going on in the workplace, whether it be that you're a provider or whether you're the nurse taking care of the patient, you can understand when people come on with certain diagnoses exactly what's going on with the patient. So I wanted to take a moment and talk about strokes, the type of strokes, what you will see with the patient so that you're not frustrated with the patient or thinking that the patient is doing something very intentional when they are not, especially when it involves the brain. Brain's very complex, very smart, covers a lot of different functions, more than we can even think about that it's doing. And some of them are just autonomic. A lot of it is autonomic, which means that it just does it on its own. So when we start with strokes, what do we mean when we say stroke? Well, there are two major types of strokes that you talk about when a patient comes in with a diagnosis of stroke. It will either be an ischemic stroke or a hemorrhagic stroke, meaning ischemia, lack of blood flow. The patient has had a lack of blood flow to a certain area of the brain. That is called an ischemic stroke. Then there's a hemorrhagic stroke, which means there has been some form of bleeding on the brain. So I want to break it up. First, I want to talk about the symptoms of stroke. So there's a lot of different ways that a patient can present with stroke, and this may be beneficial even to your family members. So if we see those things on TV like problems with acute vision changes, problems with speech, problems with motor function, tingling on one side, all of those are very strong indicators of stroke. But then there's also very subtle signs of stroke, such as dizziness. So if a patient tells you, I'm dizzy, I just can't get rid of it. It's almost like I can't see things, that things are not appropriately in place where it should be, that those are signs of a stroke. So a patient doesn't have to have a motor deficit or a speech deficit or a facial droop to recognize that the patient could possibly having a stroke. So if your patient is having any kind of acute vision change, that room flipped, something really weird, then just err on the side of caution, because there is a small window that you could possibly convert these patients if it's ischemic, meaning lack of blood flow somewhere. And so what does that mean exactly? So if a patient presents with a left facial droop, or I can't see half of the side of the room, and they scan the head, what they're looking for initially when they scan the head, if you come in within a 4-hour window, which is your window to actually be reversed. And actually there's a lot of studies on that they're trying to expand it past the 4 hours, which I think would be a great thing, because I think some more people should be intervened on. But neither here nor there, if they come in within the 4-hour window and they have symptoms that you can see, when they're scanning their head, what they're scanning for is to see if there's a bleed up there. And the reason they're doing that is because most times you may not actually see an ischemic stroke very early on. An MRI will pick that up, but it takes a while before you see that. So sometimes you'll have to get a CTA, which is angiogram, which gives you vessels of the head so you can see where the blood flow stops at. And the reason you do that is because everybody that presents with a stroke, especially if it's early on, it would not be picked up on a CT. It will only be picked up if that patient is bleeding. So if you do a CT and the patient is symptomatic and they're not bleeding, they'll probably telestroke somebody if they're not in the building so that they could prepare to give this patient a clot buster so they could break up the clot. How do I end up with an ischemic stroke? There are multiple ways that this can happen. Two of the big ways is atherosclerosis, meaning that you have too much of the bad cholesterol, lipodensity lipoprotein, which is LDL. When you break down the cholesterol, you have your total cholesterol, you have your triglycerides, your HDL, which is your good cholesterol, and your LDL, which is your bad cholesterol. And so what you want to do is look at the entire panel. But for me, what's most important, not that all of them are not important, is that lipodensity lipoprotein, which is the LDL. And the reason that's so important because it gives you a good indication as to how much plaque this patient has in their arteriovascular system. So if you have a lot of plaque in that system or atherosclerosis, it's logical to believe that as your blood is passing through, and remember the arterial system is it's a very robust system, so it has a lot of power to it. You know, when you get an ABG or when you feel a pulse and that's pushing through, like with veins, they need valves because there's no pressure in there. But for arterial systems, there's lots of pressure, there's lots of force in that system. So as your blood is forcefully moving through your body, as it should, a piece of plaque that's all congested in there will break off and travel up. And it's okay if it's in a big brachial artery or one of your subclavian artery, but just think about when it gets past your carotids and into these little bitty arteries in your head, it doesn't have anywhere to go. So the piece is bigger than the actual artery is, and it occludes the flow to the other side. And that is essentially what an ischemic stroke is. That clot cannot pass that little area in that vessel in the brain, and this patient loses oxygen because there's no blood flow there to the other side. How do you fix this? If you come in within the 4-hour window, remember there's a lot of studies showing that it's a lot more time than 4-hour windows that we're trying to accomplish here, and I wish they do that. But for now, if you're coming within that 4-hour window, you scan my head, I do not have a bleed. That means that I can get TPA, tissue plasma activator, which will break up that clot and allow me to normalize my symptoms. It destroys the clot. At that point, they'll just watch you because there is a 72-hour window that this can recur. But usually the main drugs that you will put these patients on are aspirin, and for initial one, and Lipitor or a statin, if you can take it, because these patients need to make sure that they break up all this cholesterol in the bloodstream. So that's the biggest thing with ischemic stroke. Now remember there's 2 types, and we talked about atherosclerosis, and there's also thrombotic strokes. This is big for your patients that have atrial fibrillation or have a clot somewhere. So a clot, essentially, either you have atrial fib, you form clots in the atrium of your heart, and then when you slow that rhythm down, as you should, to put blood out of the heart, you pitch a clot. And it pitches up where, as it comes out the aorta, up to your brain and causes you to have a stroke. So when things like that happen, those are called thrombotic strokes. And they'll be consistent with the vessel that it's occurring in. So always look at, when you describe a stroke, especially from a provider side, remember that you want to give as much information as you can. So you're not going to just say the patient had a stroke. That would not be appropriate as a provider. So I'm talking to providers for a minute now. So if somebody had a stroke, you want to know where that stroke was and what type of stroke it was. That gives you a lot of the information. So if a patient has a left MCA ischemic stroke, that's exactly what it is. If the patient had an MCA thrombotic stroke, that's exactly what it is. So in the instance, ischemia, most of the times atherosclerosis, or embolic strokes from pitching a blood clot somewhere. So if it's embolic, then these patients will need to be anticoagulated. So they would need more than just aspirin and statin. They would need aspirin, statin, and something to keep them from having more thrombotic events, such as Eliquis if they don't have valvular disease or something like that, which is my favorite choice. Now, that was ischemic stroke. I know I said a lot of stuff really quickly. I'll try to slow it down a little bit. Now, let's talk a little bit about hemorrhagic stroke. Why do people have hemorrhagic strokes? Well, there's a lot of different reasons. Some people, it's just they may have an aneurysm on their brain. They may not even know it's there, and then it may be harmful to them later on. By the time they find it, they've actually had a rupture of an aneurysm and bleeding in the brain. That's one of the biggest reasons that people have hemorrhagic strokes. And those are usually caused if somebody has an aneurysm and it's not coiled. Yeah, I will have PowerPoint, Shamika. I know I'm talking fast, but I will. So if somebody has a hemorrhagic stroke, usually it's probably from an aneurysm that they didn't know they had with uncontrolled blood pressure that's put pressure. Remember, the arterial system is very high pressurized. So there's a lot of pressure in the arterial system, as it should be, to get blood where it needs to be. So aneurysms are a big reason why people have hemorrhagic strokes. Some people drink and then the blood becomes too thin and then they fall and then they bleed in their brain. Or they're on anticoagulations and they fall and they bleed and they brain. But anything that occurs inside the cranium, if it's a bleed and it affects a part of the brain and you act like a stroke, it's a stroke, okay? So 2 types, ischemic or hemorrhagic. Now, both of these all of these strokes, no matter what the etiology was or the cause behind the stroke, they all pretty much cause the same symptoms when it affects the area. So say you come in with an ischemic stroke and you're outside of that 4-hour window, then what happens? Then there's a risk and they can't TPA you. Let's talk about that a little minute too. Say that they can TPA you. Well, if they TPA you, they're meaning that they will break that clot up or break that area of ischemia up. There is still a high potential that that will turn into a bleed. So that's why they watch these patients very closely, and a lot of times put these patients in ICU, because the risk of converting from an ischemic stroke to a hemorrhagic stroke is very, very, very high. So these patients get watched very closely. I'm going to put some slides out on all of this tomorrow, y'all. I'm trying to make it as simple as I can. But I want to talk about what strokes do, because this is the very important part. Remember that the brain is very complex. It's meant to function and do a lot of different things. Each part of the brain gives us a different sensor of things that we do. Honestly, I don't remember them all. I remember a few of them. I look them up as I need to. And if a patient came in with a frontal stroke, those are usually very, very, very pronounced. So those patients come in usually sometimes with behavior problems, because that's the part of the brain where you have personality and behavior. So sometimes if you see somebody that's hypersexual, it's because they've had a frontal lobe stroke and they don't know what to do other than that. The brain is creating this behavior. So a lot of times you'll see strange behaviors and strange personalities, and those are usually your frontal strokes. You have your occiput or your occipital strokes, and those people, that's where your vision comes from. So those people will have lots of vision changes. They will be chronic. Remember that if you've lost that part of the brain tissue, you don't get it back. So that's the way they live from here on out. If you had a cerebellar stroke, that means that you have dizziness, you have ataxia, you have problems with balance, because that's where the part of the brain that controls balance. If you had a temporal stroke, then that's a lot of sensation, touching, things like that. If you had a parietal stroke, then that's the part where abstract thinking, arithmetic, spelling comes from, things like that. And then if you had a temporal stroke, then those patients usually have a problem with making sense of things and language. So I'll put slides out on this tomorrow, but I wanted you to be careful about judging patients. Not that everybody does, but some people laugh, and it's not really funny because these people cannot control what they do. So a lot of times, remember that the brain is complex, and whatever part is affected is controlled by it, and you exhibit behaviors consistent with the area where the stroke was. Does anybody have any questions? Thank y'all so much for joining my live. I've been gone a long time, so the support is great. I really, really, really appreciate that. All right, y'all, I'm going to put some slides up tomorrow. Thank you so, so, so much for your support. God bless.